Ehlers-Danlos Syndrome Nursing Educational series. This series is being offered by EDS Awareness, a group whose foundation is to support sufferers of EDS and its related conditions. EDS Awareness provides several links for further education via lectures and webinars. More information about EDS Awareness will be provided. Our goals for this series are to help healthcare professionals recognize symptoms that a patient might have EDS, but also to help EDS patients and families better navigate the healthcare system so that they are able to get a diagnosis and treatment in a more timely fashion. This series provides official CEUs in the American nursing system and educational hours for revalidation in the systems in both Australia and the UK. My name is Catherine Haig. I am currently an emergency ophthalmic nurse practitioner specializing in neuro-ophthalmology. I work in the NHS in England. Also, part of my role is clinical education of nurses in my department. I have personal history and family history of EDS. At this time, I'd like to thank John Furman, the founder of EDS Awareness, and Beth Fahlberg, the organizer of this series, for the opportunity to participate in this educational series. Through our support groups and informal surveys of patients and nurses, EDS Awareness recognized that there was a need to offer professional development education for nurses and allied professionals. As frontline caregivers, you are the ones who are involved in monitoring the symptoms, provision of care, and this occurs during a particularly difficult time for both diagnosed and undiagnosed patients. You are the ones who can report new symptoms, change symptoms, and advocate for those investigations, treatments, and measures that will directly impact the patient pathway in the medical system. So to get started, EDS is a group of connective tissue disorders. Most appear to be the cause of gene mutation. However, in some families, a cause is not able to be recognized or identified. It was originally associated with hyperelasticity of skin and hypermobility of joints, hence the origin of its name. The term EDS has been used since 1936 and is named after the Danish dermatologist Edvard Ehlers and the French doctor Henri Ehlers-Danlos, who had a special interest in the chemistry of the skin. Symptoms we now associate with EDS have been around for centuries. In fact, descriptions of hypermobility have even been found in the cases of Hippocrates. Though often associated with its most common symptoms, skin hyperelasticity and joint hypermobility, through genetic research and medical advances, we now know that EDS encompasses an entire spectrum of symptoms and secondary diagnoses. EDS expert Professor Rodney Graham has been quoted as saying that EDS is one of the most neglected diseases in the history of modern medicine. When defining what EDS is, I think it's also important to define what it is not. It is not a collagen vascular disease, nor is it an autoimmune disease. It may have very similar symptoms to those types of diseases, for example, pain and fatigue. However, these symptoms are related to the breakdown of connective tissue and the body's coping with that. A patient may also have one of those diseases as well as EDS, further complicating the presentation. They also may have other comorbidities, such as diabetes, hypertension, etc. I know a person who has lupus, which is a collagen vascular disease, and Hashimoto's, which is an autoimmune disease, and EDS. So this person is proof of a medical principle attributed to John Hickam called the Hickham's dictum, which states that a patient may have as many diagnoses as they damn well please. Said, EDS, by definition, is a genetic disorder that affects collagen and specific proteins in connective tissue. To better understand it, I think it's necessary to review some anatomy and physiology of connective tissue. Connective tissue is the most abundant type of tissue in the body. It provides supportive structure for organs and for movement, so any defect in this will have a huge impact on bodily functions. All connective tissues have the same embryonic origin. They are mostly non-living material and have varying degrees of vascularization. Connective tissue is mostly comprised of cells and extracellular matrix. Extracellular matrix is made of ground substance, which is mostly proteins, starches, and water, and then fibers. These range from strong fibers like collagen delicate fibers like reticular fibers, and then elastic fibers, which can be found in like the skin and the aorta. For our purposes, we will type them according to function. So the three types we will consider will be fluid, fiber, and supporting. Fluid can be seen in blood and lymphatic systems. Fiber, which is also called connective tissue proper, can be seen in the organs and blood vessels and the supporting structures. And supporting connective tissue, which is the more firm supportive tissue, can be found in cartilage and bone. Fluid connective tissue is quite obvious. Fibrous connective tissue, or connective tissue proper, has two categories, loose and dense. Now, each one of these is further subdivided into three more categories. So in loose connective tissue, you have areolar, adipose, and reticular. Areolar tissue is found in organs and blood vessels. Adipose can be both brown or white. Brown adipose tissue generates heat and is more abundant in infants, while white adipose tissue stores energy. Reticular tissue can be found in the spleen, lymph, and bone marrow. And with dense connective tissue, you have regular, irregular, and elastic. Regular is found in tendons and ligaments, irregular in skin and periosteum, and elastic in the arteries, trachea, and vocal cords. Supporting connective tissue includes cartilage and bone. There are three types of cartilage: hyaline, fibrocartilage, and elastic. Hyaline cartilage, most nurses will be aware that is in the respiratory system, synovial joints, and the nose. Fibrocartilage is in the spinal discs and the knee meniscus, and elastic cartilage is in the epiglottis in the ear. With bone, there are two types of bone, spongy and compact, and as this diagram illustrates, there can also be articular cartilage at the end of these particular bones. The combination of connective tissue throughout the body basically holds the body together. Though EDS is listed as a rare disorder, the prevalence is thought to be significantly higher. It is an extremely underdiagnosed disorder, especially the hypermobile EDS, which is thought to be possibly less than 1 in 5,000. As for prevalence, it does seem to have equal prevalence in men and women. However, symptoms in women may be accelerated and much more debilitating after puberty, whereas in men they seem to improve. This seems to be directly attributed to hormonal influences. As far as ethnicity goes, it seems to be similar across ethnic groups, but one must consider the many factors, including reported data, how many people actually get to a geneticist, and the access to healthcare, which varies internationally. Most forms of EDS are recognizable in childhood, however, some do manifest later in life. As awareness increases, many people are now diagnosed in early adulthood. Because there is such a variety of symptoms and the degree of those symptoms, it can take 10 to 20 years to be diagnosed. This brings to light another medical principle called the Occam's razor, which suggests that if you have many varied symptoms, consider a single cause. And I do think this is quite appropriate for EDS. As of 2017, there was a reclassification of the diagnostic criteria for the subtypes of EDS. There are now 13 recognized subtypes, and now that we have reviewed the functions of connective tissue, you will see that they are directly correlated with the tissue that's most effective. There is a webinar by Dr. Claire Francomano, who is an expert in EDS, which is available on YouTube and goes into great detail for each of the subtypes. Just to go over some of the subtypes and the major symptoms that accompany them. Number 1, classical EDS includes hyperelasticity of skin, atrophic scarring, and joint hypermobility. Number 2, classical-like EDS is very similar with hyperelastic skin, joint hypermobility, and bruising, but without the atrophic scarring. Number 3, cardiac valvular type is again has the hyperelastic skin that you see in 1 and 2, and hypermobile joints, but in addition to that, they have severe problems with cardiac valves. And number 4, vascular EDS. This is a rare but very serious type of EDS. These patients may be at risk of arterial rupture and organ perforation or rupture. Number 5, hypermobile EDS, probably the most common type by far. Patients have hypermobile joints and musculoskeletal problems and also generalized connective tissue problems. Number 6, arthrochalasia. These patients can have severe generalized hypermobility, congenital bilateral hip dislocations, and hyperelastic skin. Number 7, dermatosparaxis. These patients may have extremely fragile skin, and it's also often associated with a specific structural feature of the facial bones. Number 8, kyphoscoliotic EDS. These patients have a congenital kyphoscoliosis, muscle hypotonia, and joint hypermobility that can include subluxations and dislocations. Number 9, brittle cornea disease manifests with an early onset of keratoconus, which is a cone-shaped cornea, keratoglobus, and may include a blue sclera. Number 10, spondylodysplastic. These patients are of short stature, they have bowing of limbs and muscle hypotonia. And number 11, musculocontractural EDS. These patients exhibit multiple congenital contractures like clubfoot, plus skin fragility, bruising, palmar wrinkling, and again have specific facial bone structure features. Number 12, myopathic EDS, involves proximal contractures, yet hypermobility of the distal joints. They may also have congenital muscle hypotonia. Number 13, periodontal EDS. These patients have early severe periodontitis and can have a lack of attached gingiva. There's a very strong family history in this particular type of EDS. So what does an EDS patient look like? These patients have a chronic systemic multisystem condition. According to what type they have, some symptoms may be due to the primary cause and some symptoms may be due to secondary diagnoses. Patients with hypermobility EDS may have varied connective tissue disorders. They may have GI issues that varies from IBS to poor motility to even gastroparesis. They may also have comorbid conditions like any other patients, like high blood pressure, diabetes. They may have arthritis in the damaged joints. They may also have associated conditions such as a condition called POTS, which is postural orthostatic tachycardia syndrome, a dysautonomia, or a mast cell activation disorder. Their symptoms can vary, therefore they can impact their lives differently at different times. You might see one patient impact their lives differently at different times. You might see one patient who's an athlete who has some joint hypermobility and pain. You might also see a patient who is severely debilitated or even bedridden. So to summarize Section 1, EDS is a genetic connective tissue disorder with 13 subtypes. It is systemic and chronic. It's underdiagnosed and can have a significant impact on a patient's life.